Good evening, everybody. And for those of you thinking Colin sounds a bit strange this evening, Colin is taking a well-earned rest this week. He's on leave. I'm Emma Malcolm. I'm the Interim Director of Services, and I'm going to attempt to be as good as Colin tonight for him. So yes, if you're thinking to yourself, it says Colin Daniels and it doesn't look much like Colin, that's why. So our speaker this evening is Noemi Lois. Noemi is a Professor of Ophthalmology at Queen's University in Belfast and a consultant ophthalmologist and vitreoretinal surgeon, I really had to practice that, at the Belfast Health and Social Care Trust. She's been looking after people with diabetes as a consultant ophthalmologist for over 23 years, and the past 10 years, the main focus of her research has been diabetic retinopathy and its complications. Noemi's going to talk to us this evening about the results of a recent trial for patients with diabetic macular edema. But before then, I just thought you might all be interested to know that one of Noemi's first ever grants when she came to the UK was from the Macular Society when she was at Moorfields. So it's wonderful to see just how our funding helps researchers. So marvelous. So Noemi, I'm going to hand over to you.
Thank you very much, Emma. That's great. And indeed, I am very fond of the Macular Society because I started with you. So thank you very much. So I would like to talk to you about diamonds, and that's the trial that Emma was referring to on diabetic macular edema. Before I do so, I'm just going to take you through what is going to be the whole topic of the talk. So I will start by telling you few words about what diabetic retinopathy is. Probably most of you know, but I think it's good to review it first. Then I'll say a few words about diabetic macular edema, and then I'll review with you and for you how is it treated, and then I'll go into the result of diamonds. I think that will allow you to understand a little bit better everything that I'm going to say about diamonds. So what is diabetic retinopathy? Basically, we can say that is the term that we use to describe the changes that occur in the back of the eye, in the retina, in people that have diabetes. And probably most of you have heard the words non-proliferative diabetic retinopathy, and people refer to NPDR, and proliferative diabetic retinopathy, and people refer to PDR. And I'm going to explain this now. So early on, when people are diagnosed with diabetes, oftentimes there's no changes that we can see in the back of the eye. And what I'm showing you here is a photograph of the central part of the eye. So there's retina around this area, but this is the center. Here we have on the right side of the picture, the nerve in the back of the eye. And then these lines around are the blood vessels in the back of the eye. And right in the center is the macula. The macula would be a larger area, and the darker area here is what we call the fovea. And the fovea is really the central part of our retina. And when we look at something directly, that's the bit of the retina that we are using. So initially, there's no changes. And then as years pass by, the diabetes makes changes in the back of the eye. And we can see here, for instance, very, very little dots that look red. These would be little hemorrhages. Also, there's little round dilations in the blood vessels. They are called microaneurysms. And so, from not having any changes in the back of the eye, people might develop mild changes, and we call it mild non-proliferative diabetic retinopathy, mild NPDR. As time goes, some people, not everyone, by the way, not everyone, but some people might still progress. And then we see more changes. We can see little white spots here. This is again the nerve in the back of the eye, the blood vessels, the center, the fovea, the macula. And you can see little hemorrhages, round little things that might be microaneurysms. And then we see white areas. And these areas are basically areas of what we call infarction, where the blood is not circulating well. We call them cotton wool spots. Maybe you heard that before. Then again, some patients, not everyone, might progress to the next stage, which is called severe non-proliferative diabetic retinopathy. And on here, you can see many more changes. So there's white yellow spots here, and this is pretty much lipid, fat, that comes out of the blood vessels. And then we see more hemorrhages, so more changes, more severe changes, and that's called severe non-proliferative diabetic retinopathy, NPDR. And again, very few people might develop what we call proliferative diabetic retinopathy. And why proliferative? Because there's proliferation, growth of abnormal blood vessels in the back of the eye. So in diabetes, the blood vessels are a little bit abnormal, but these ones that they grow, they are even more abnormal. So they tend to bleed, and I am showing you here an eye that has a bleeding and it looks red here. And sometimes these blood vessels bring a scarring with them. And the scarring, like scars do, can contract. And if the scars contracts, pulls on the retina. And if it pulls in the retina, it can detach it, causing what we call a tractional retinal detachment. Again, very few people will develop proliferative diabetic retinopathy. We see many people in our clinics because diabetes is so frequent now throughout the world that because there's many people with diabetes, we see more people with proliferative diabetic retinopathy. But the majority of people will not develop this complication. So proliferative diabetic retinopathy is one of the sight-threatening complications of diabetes in the eye. The other sight-threatening complication of diabetes in the eye is what we call diabetic macular edema, or DMO in short. So DMO is a complication of diabetic retinopathy in the back of the eye. It happens again like proliferative diabetic retinopathy. It happens also in few people living with diabetes, but because there's so many people with diabetes, we tend to see it quite often in our clinics. What happens? Well, in diabetes, we have a weakness in the blood vessels. So the blood vessels are a little bit weaker as a result of the disease. The blood vessels carry fluid, they carry blood, they carry lipid, which lipids means fat. All of us in all our blood vessels have that. Because in diabetes, the vessels are a bit weak, they are leaky. And so the fluid, the fat, the blood can leak through, and instead of being kept inside the blood vessels, it can go into the retina. And if it goes into the center of the retina, what I call, and I explain, is the macula, the area that gives us our central sight, even if it goes into the fovea, the really center of the macula, then we'll call it DMO, diabetic macular edema. And DMO can occur in any stage of retinopathy. So even when we have mild diabetic retinopathy, diabetic macular edema can occur. And here are the pictures of diabetic macular edema. I'm showing you here on the left side an eye as similar to the one I showed you before, with a little bit of the nerve being seen, the retinal blood vessels, and then the center, the darker area, the fovea, and all of these would be the macula. And so this is an eye with no disease, and the blood vessels look good, the retina looks good. Somebody that has diabetic macular edema may look like this. So this is an eye with diabetic macular edema. As you can see, it's a little bit less sharp because there's fluid there. There's yellow material, which is the fat that has come out of the blood vessels. And then we have the dark spots, the red spots, which are hemorrhages. That, of course, hemorrhage, the blood came out of the blood vessels too. This is what we see when we look at somebody in the machine called a slit lamp, which you will see if you have seen an ophthalmologist or an optometrist. We look through with a little lens and we look at the back of the eye with a light. And this is how we see it. We can also nowadays do scans, what we call optical coherence tomography scans, in short, or CT scans. They are done with a laser ophthalmoscope, like I'm showing you here. And then again, if I show you the scans, in this eye with no disease, this is how it will look. So we'll have the retina with the different layers. All of this is the retina. And then we have the center of the retina, which is the fovea. It has a little depression, and that's how it should look. But when you have diabetic macular edema, the fluid accumulates in the center here. And then what you see is dark. This is the fluid filling the retina. So this is diabetic macular edema. So how do we treat diabetic macular edema? Essentially, and mainly, depends on, firstly, whether or not involves the center of the macula, whether or not involves the fovea. And if it involves the fovea, we'll say center involving diabetic macular edema. If it doesn't involve the fovea, we say it's non-center involving diabetic macular edema. And then it also depends if it's center involving on how severe it is. And based on that, we decide whether or not we need to treat and how we need to treat. Because sometimes there might not be necessary to treat, and we can keep an eye on things. And I'm going to show you one of these cases. So this is a patient of mine in the right eye. This is a scan of the back of the eye, and this is now the scan through. And you can see that there's white spots in the scan, several white spots. I think that you can see it in my arrow. Emma, can you see my arrow on the slides? Great. So these are the corresponds to those little white dots, which in the photograph would appear yellow. So this is the fat that has come out of the blood vessels. And then here we see a darker area, and that is fluid. So this would be a non-central involving diabetic macular edema because it's on the side, it's not here in the middle. In the left eye, this is the left eye here, the photograph, you see a white spot there. That's lipid right in the center, that's fat, right in the center of the fovea. You can see it here. And there's fluid here, looking dark, and fluid here, and more lipid there. So when I was in the clinic and I saw this gentleman, I say, well, you know, we can do something for you that doesn't involve a treatment to the eye, but involves a treatment of your body. And a few months later, this is how the same gentleman looked. So as you can see, most of, well, the fluid went away. Most of the white dots have nearly disappeared, as you can see, especially in the left eye. All that plaque that I will say of lipids is gone, as you can see. And the retina looks much better. All the fluid is gone, and I haven't touched the eye. So what did I do? Well, I called the GP, and I say to the GP, I feel that likely the blood pressure might be a little bit high, and likely the lipids, the cholesterol, the triglycerides might be high. So can you look into this? And the GP did, and provide treatment for both. And just with the treatment of the blood pressure and the cholesterol, the retina improved and the sight improved. And I didn't need to do any treatment locally. But sometimes, of course, that is not enough and the fluid remains. So I showed you how the right eye of this patient had non-central involving diabetic macular edema. So this is the fovea, this is the fluid here. So how are these patients treated? I think that everybody pretty much in the world agrees, which is quite difficult for everyone and all the doctors to agree to anything. But I think that for this, everybody agrees that the treatment of choice should be macular laser. And that's the treatment I'm going to discuss a bit later on. So, and in theory, to be honest with you all, if we are monitoring you all appropriately, we should be able to pick up the disease early. And if we pick up the disease early, we will pick the fluid before it goes into the center. So then macular laser treatment could be done. Because then when it goes to the center, and then we call it central involving diabetic macular edema, then which treatment are we going to choose depends on how severe it is. That's what I was referring before, depends on how severe it is, the severity. If we have a lot of fluid, like I'm showing you in this picture, the retina is very elevated, as you can see, there's no depression, there's no what we call the umbo, what is the depression in the fovea, that does no longer exist. There's a lot of fluid in this retina. And when this is like this and the fluid is severe, the treatment of choice is antivascular endothelial growth factor therapies. And I'll review that for us in a second for you. But if we have mild edema, like in this case, even if it's in the center, we can treat with macular laser. So what we say severe, and I showed you a case of severe, and I showed you a case with mild. Is there any other way to define it? So the NICE, and I don't know if you know and if you have heard about NICE, but NICE is the National Institute of Health and Care Excellence. It was set by the government to determine which treatments we should incorporate into clinical practice. And what NICE does is they look at any new treatments, they look at how well they work, what is the benefit to patients, and they look at the cost. Sometimes people think that they only look at cost, and that's not true. They look at how effective the treatment is for the cost of the treatment. If the treatment works well, they will be funding it. So they looked at the whole treatment of diabetic macular edema with anti-VEGFs, anti-vascular endothelial growth factors. I'm going to refer that in my next slide. And they say that if the retina is thick, being severe DMO, and they measure the thickness being severe as when it is over 400 microns. So that thickness of the fluid we can measure on the scan. And we can take that measure, and if in the very center of the retina is 400 microns or more, we could call it severe. We know that those eyes will not respond well to the laser treatment, and anti-VEGFs are the treatment for them. However, if when we measure that central thickness on the scan is less than 400 microns on the scan, and the scan measures that for us, we can measure it in that manner, then the NICE showed that macular laser treatment seems to work well because it can go through the thinner retina and then it can make an effect. And that's why NICE proposes that we use, and they advises that we use anti-VEGFs when the central retinal thickness is 400 microns or more. When it's less than 400 microns, they advises us to use macular laser because macular laser is going to work well and is less expensive. So just to say a few words about anti-VEGFs, again, VEGF is what we call vascular endothelial growth factor. And we know that people that have diabetes may have high levels of anti-VEGFs in the eye, of VEGF in the eye. And this VEGF makes the blood vessels leaky. And so that's why the anti-VEGFs were developed to block the effect of the VEGF and prevent the blood vessels to leak. So these anti-VEGFs are given as injections inside the eye. So we need to prick the eye and give the treatment inside the eye. At the beginning of any treatment with anti-VEGFs, we need to do them frequently. Frequently meaning every month. For the first few months initially. And there's now several anti-VEGFs. And depending on the anti-VEGF, it might be that we need to do 6 injections every 1 monthly, or 4, or 5, or 3. So it's different depending on the anti-VEGF that we use. But initially, it's going to be 1 injection every month. We know that sometimes then the fluid clears, but that doesn't mean that the fluid is not going to return. So usually patients go on treatment on and off for years. So we know that in one of the trials, they follow people and they show that at year 5, around 30 to 40, or even a little bit higher percentage of people. So I will say 40 out of 100 people will still be receiving injections, maybe even higher, maybe even half of the people that started, they would still be on injections 5 years on. These injections, of course, they don't cause a lot of pain, but, most of the people would prefer not to have an injection. And they have potential complications such as increased pressure in the eye, or the retina could detach, or a cataract could form. And the most dangerous one is infection. although this happens extremely, extremely rarely. These are the anti-VEGFs. They are very good when you have a lot of fluid, when you have florid, severe macular edema, because often we can clear it. We need to give the injections regularly and frequently, but they are extremely helpful. And that's the best treatment when the edema is severe. But as I say, when the edema is not very severe, macular laser is a great choice as a treatment. I want to clarify this because I work with patients, as I will say to you shortly, all the time in the research I do, and of course in the clinic I'm with patients every week. And sometimes people confuse macular laser with the laser that we do for proliferative diabetic retinopathy, which I was referring to at the beginning of the talk. And when we do the laser for proliferative diabetic retinopathy, that laser is called pan-retinal photocoagulation. And that laser is stronger, much stronger than the macular laser. Sometimes it causes pain. Of course, we can give you anesthetic. So I'm happy to discuss that later on if anybody wants, but we can give anesthetic and then the laser doesn't hurt. But macular laser doesn't hurt at all. You don't feel a thing. It's done with a lens, and this I'm showing you, this is a laser that is given through a slit lamp, just like when we look at the back of the eye I showed you before. But we place a lens in the eye, it's in contact with the eye. So we put a little anesthetic in the eye and we put the lens in the eye so that we can focus very well the laser on the retina where we want to apply it. So the laser is applied in one session. So we do one session, takes about 10, 15 minutes, all done. Topical anesthetic. And then at the beginning, we might need to repeat it. So it might need to be repeated every 3 to 4 months. And I'll give you now shortly the result of Diamond. So that will give you an indication of how many treatments most of the people need. Now, there are 2 types of laser. So there's a standard laser, I call it a standard laser, because that's the original laser that we use for many, many, many years to treat diabetic macular edema. When we apply to the retina, it produces a small little burn. Years ago, when I was a resident, people used to do the burns quite intense. That was great, it cleared the fluid, but it creates a big scar. As time went, we realized that you don't need to be that strong. You can go very mild with the laser. You produce a very small burn, and the laser still works. And it clears the fluid from the back of the eye. But then they developed this micropulse laser. And we can do this micropulse laser in what we call subthreshold way. So we call it subthreshold micropulse laser. I'm going to abbreviate it, if you allow me to, as SML, subthreshold micropulse laser. Well, this laser doesn't produce any burn whatsoever in the retina. Nothing. We do it, we see no change to the retina. There's been studies in animal models of disease in which we can take the eye, put it under the microscope and see what has the laser done. And we don't see any damage whatsoever from this laser. We apply it and we see no damage. People, ophthalmologists, didn't believe that it was going to work because it's not burning, it's not doing anything. They couldn't see anything. So at the beginning, nobody believed that it would work as well as a standard laser. And so what happened is then, people say, well, I don't think that this does anything. And there's no evidence that it works as well or better or worse than a standard laser. And because of that, our National Institute for Health and Care Research, who is the national institute that supports and funds research in the NHS in the United Kingdom, they commission a trial. What does it mean, commission? It means that they say to all the researchers in UK, we want somebody to do a trial comparing these 2 lasers for diabetic macular edema. Because obviously, if the subthreshold micropulse laser that doesn't cause a burn, that doesn't cause any damage to the retina works, well, that would be great for people. So they commissioned the trial, and we, a group from here and from throughout different places in the UK, as collaborators, applied with us, and I was leading it, so that's why I was asked to present this trial today to you. So we put together our proposal for Diamonds, and we got the bid, so we were funded. And then we started the trial. And the trial was called Diamonds. And the goal of Diamonds was to test the clinical effectiveness, which means how well this laser works, and the cost effectiveness, how much it costs. So how well it works, how much it costs. These treatments, or this subthreshold micropulse laser, were compared with the standard treatment, and the standard treatment was the standard laser, the one that produces a small burn, for people that had central involving diabetic macular edema with central retinal thickness, as I say to you, less than 400 microns, because this is the people that we knew would respond best to the laser. So we conducted the trial in 16 hospitals across the United Kingdom, and we recruited 266 participants in the trial. So it was a large trial. In trials, what we do is we treat people with one treatment. It would be the standard laser. That was the standard treatment. And then we treat another group of people with the subthreshold micropulse laser. And then we follow them on, and then we see who does best, or maybe they do the same, or one does worse than the other. And that's what we did. Who goes into one treatment or another is decided by chance. And to that we call randomization. So you might hear us talking about randomized clinical trials. And it's because the selection of the treatment is given by chance. So some patients will receive one treatment, some patients will receive the other. And then we follow the patients for 2 years in the trial. So it was quite a long trial. And then we evaluate the effects of the treatments and the costs, as I mentioned. It's interesting because, unfortunately, Diamonds, the second year of Diamonds, fall within the COVID crisis, as you can remember, unfortunately. But all the units and all the participants were outstanding. We make our clinics safe for them to come, and we still managed to evaluate everyone through the COVID crisis. And so we completed this trial successfully, which was really a miracle. And I'm so pleased. And everyone paid a lot of, work to make sure that it would be safe for everyone. And the patients were fantastic coming for the follow-up visits, even at those difficult times. And one thing I feel extremely proud about in Diamonds is that we had the excellent support of a patient and public involvement group. Some of you might have heard about patient and public involvement groups in research, some of you might not. So I will just explain this to you. So these are patients like yourselves or the public. Maybe some people that don't have diabetes is listening to this talk today. But they are keen, they might have family members, they are keen to help research. And what they do is they help us, telling us things that are very important. Patients know more than me about diabetes, no question about it. They have diabetes. They know more than me about diabetes. And it's very important for me to hear from them, to design trials that are important to the people that live with diabetes. And so we assembled this Diamonds Patient and Public Involvement Group with the help of Diabetes UK. And we have a Diabetes UK group here in Northern Ireland, Diabetes UK in Northern Ireland. And I'm very fond, we are like really family. I really feel like family. We got together since I moved up here, and we worked together since I started doing the research here in diabetes. And how did they help on the trial? Well, firstly, at the time that we designed Diamonds, we met with them, and then we discussed what we were trying to do. We tried to see whether this laser is better than this other laser, or whether they are the same. What are important things that we should measure in this trial for patients? And so this is what we call selecting outcomes for the study. What are we going to measure? we need to measure things that are important to patients. And actually, straight from patients with diabetes, we heard them saying to us, well, you know, for us, what is important is we want to keep driving because that keeps us our independence. So please, could one of the outcomes be the ability to meet driving standards so that we can keep driving? We had not thought about this outcome ourselves. So had the patients not told us, it wouldn't have been on the trial. And so the outcome came directly from them to the trial, and that's wonderful. The patient and public involvement group help us to design the trial so that it would not be too burdensome on patients, so that the tests we did were standard tests that are done usually in clinical practice, so it wouldn't add too much work to the patients. And also, of course, they help us producing the documents for the trial, like the information for the patients about the trial, so that when they read the information, they clearly understood it. They also help us then to interpret the data coming out from Diamonds, and they are helping us now to disseminate the results. And of course, the Macular Society today is helping us to disseminate the results too, so that you're hearing about them. And also, it was very important because the Diamonds group met at the end of the trial, and they gave us important clues on what the next trial should be. And on those bases, actually, we have designed the next trial. We had applied also to the NHR, who funded Diamonds, the National Institute for Health Research that I mentioned to you before. And so we have put the trial forward. So hopefully, if they fund it, we will get the next trial, and that will have been with the help of our patient and public involvement group. And so what did Diamonds demonstrated? Well, believe it or not, it demonstrated that the subthreshold micropulse laser that doesn't burn the retina is as effective as a standard laser that causes those small burns in the macula. So it works as well to clear the fluid and to keep the sight of the patients throughout the 2 years of the trial, because most of the patients kept their sight throughout the 2 years of the trial. Most of them, 95 out of 100, 9 out of 10 or more, 9.5 out of 10, kept the driving standards, so managed to continue to drive. Few, 9 in 100, lost sight, not permanently, but at year 2, they have lost 10 letters. So these patients continue on treatment. So maybe some of them will still recover the sight. This is not much different than with anti-VEGFs, for instance, even when we are treating people that have minimal fluid. Some patients, though, did need injections here and there, not all the time throughout the trial, but here and there, because sometimes, despite of the laser, the fluid may have gone thicker, or the sight may have gone down. And then we did offer, of course, the injections, because the fact that you receive laser doesn't mean that, oh, you cannot receive any injections. If you don't respond to it, you can still get the anti-VEGFs. So about, I would say 20 in 100 patients might need to have some anti-VEGF treatment here and there throughout the trial. The laser itself caused no side effects, neither of the two, by the way. So both treatments are very safe. But of course, because the laser needs to be given on and off, maybe throughout the years, because of course, you know, if you are in your 60s or in your 50s and you develop edema, or even when you're in your 20s or 30s, you might require treatment throughout your life here and there. So because it doesn't burn the retina, it's a good thing. The cost of the treatment was small. The cost of the subthreshold micropulse laser, and this is not just the applying the laser, but the whole cost of treatment throughout the 2 years, was less than £900 in the subthreshold micropulse laser, and a little over 1,000 in the standard laser. One injection alone is around £800, so you can imagine. So, in conclusion, the subthreshold micropulse laser works as well as a standard laser, and Diamonds prove that. It's not expensive, and it works well clearing up the fluid and maintaining the sight in people with diabetic macular edema that when we measure with the scanning laser ophthalmoscope, the OCT that I showed to you at the beginning, if it's 400 microns in the center, it works well. And so doctors, and I like to tell all patients, to know about it. Doctors should offer it to patients when the central macular thickness is less than 400 microns. And also, of course, if the diabetic macular edema doesn't involve the center, and macular laser is going to be offered. Because, of course, I think it's a great thing to know now that this laser works the same and it doesn't burn the retina. So we can repeat it if we need to. In the trial, I was going to say to you, the average number of injections that people, of lasers that people require was 2 to 3. So in the standard laser, the average was 2. In the subthreshold micropulse laser, it was around 3 lasers in 2 years. So it's not a lot of treatment. Can be repeated, and as I say, if the edema doesn't respond, we can do an injection and then keep going with the laser. If the macular thickness increases and the laser doesn't control it, we can do an injection and then continue with the laser when it's a bit thinner, when it's less than 400 microns. And if the vision goes down, we can do injections to try to bring the vision up. And when the vision is good, we can continue with the laser. So it's a good piece of armamentarium we have there to treat people with diabetic macular edema. With this, I finish, and I want to, of course, thank all the sites that took part on Diamonds, and we had 16 sites besides mine here in Belfast throughout the UK. We have the NIHR, as I mentioned, who funded the trial. The clinical trials unit here in Northern Ireland helped me to run the trial throughout the UK. We have also the clinical research networks, which are the network is funded also by the NIHR, and this is a network of research which has research nurses, optometrists, a staff supporting trials throughout the UK, and all the hospitals have one. So the clinical research networks in all these 16 sites supported the trial. Our Diamonds PPI group, as I mentioned to you, who were, of course, an essential part of Diamonds, and of course to all people that took part in the trial. And I'm always very grateful to all the participants in any research, because without them, we would have nothing. We would have no treatments. If people don't participate in trials, we would have no treatments for anybody. So I'm very grateful to them. And of course, I'm very grateful to your attention. I'm very happy to discuss anything, even if you have questions that are not fully related to Diamonds. Thank you for your attention.
Noemi, thank you so much. That was so interesting. I've got some questions, but I can see that Bernie's got her hand up. So Bernie, I'm going to let you talk and ask first.
Hello, Noemi. That was a brilliant presentation and so clear. Thank you. My question is this, and it's a concern that I've had a few conversations over the last couple of days about this. The cost, obviously, per laser is less, but does the hospital need to have a different kind of machinery to do this laser? Is there a cost to the hospital to bring a different laser in or something in order to do this lasering? Or have all hospitals already got what they need to be able to do this this type of lasering?
And that's a great question, Bernadette, and good to see you today, by the way. So yes, so let me tell you how it goes. So lasers usually are replaced every 8 to 10 years in the NHS. So most of the units will be changing them periodically. The new lasers that are available for macular laser tend to have both modes, a micropulse mode and a standard mode. So most of the newer lasers will have both. So certainly there would be units in the UK that might not have these lasers yet. I think that it would be important that we all, help disseminating findings, because of course people can put business cases in their sites to say, well, there's now this laser that works. If we catch diabetic macular edema early, it should be non-central involving. If we catch it a little bit later, it should be central involving with less than 400 microns. So only when we catch it much later, it would be over 400 microns. Initially, the sight is usually good. So we treat early with good sight. We can treat with macular laser. We treat with macular laser that doesn't burn. There's no side effect. So I think it wouldn't be that difficult to put a business case to get the laser. And as I say, most of the new lasers, so units will need to start changing. The laser is necessary for treating proliferative diabetic retinopathy, and also for treating other diseases. For instance, we use it to treat retinal breaks in the retina, when people come with breaks and prior to them developing retinal detachments. So every unit in the UK needs to have a laser. So when that laser needs to be, upgraded, you will need to choose a new laser. And if you choose right enough, again, most of the new lasers would have both modes. So then everyone will have a micropulse laser.
So Noemi, do we know at the moment which centres have these lasers and which don't? And is there a, what's the role that that NICE has in ensuring that hospitals have this equipment? Because you've shown, haven't you, that the cost is less. So actually, and that there's huge benefit to patients that will also reduce cost long term. So how do we ensure that all centres have this equipment so any patient for whom this is relevant can get this treatment?
And again, you are both raising the main, this is the main issue. And that, when I moved here and I started doing the research with NHR, I kind of was a little bit naive, because I thought the government, because the NHR is the government, really, the government commissions a trial. That was diamonds. If the government commissions a trial and the trial shows that the treatment works equally well, so they can say, and some people might say, well, it works equally well, so you can do either. So you can keep going with the treatment that produces the little burns because you didn't see a difference. Obviously, we know that there's a structural change in the retina. So, whereas if there's no structural change in the retina, you could do it indefinitely. Of course, if you produce little burns, although they are little, if you need to do more and more and more, it wouldn't be that little anymore. So clearly, there should be an advantage longer term of not burning the retina. And I was thinking, well, the government should say, the NHR should probably say to every hospital now, well, we have this evidence. We need to put it into place. We need to get these lasers for every site. Now, Bernadette knows very well because she is part of the NICE guidelines, like I am. And if hopefully the NICE guidelines say that this laser should be advocated and should be used to treat diabetic macular edema instead of using the laser that burns, then people really at each site can go to their managers. And my manager certainly says here, and I have one, fortunately for my patients, so I don't have to say it, but I went to my manager and I say, listen, this is the data from Diamonds, which we ran. And they, of course, got the laser. Because as you say, Emma, it pays off longer term. And I think that we will see, hopefully, and I cannot say anything, but the guidelines from NICE will come out for consultation. My hope is that it will clearly be stated in the guidelines that these lasers should be favored. Interestingly enough, when I'm sitting in the NICE panel for the guidelines, and Bernadette knows this, I seem to be conflictive because I am the chief investigator of Diamonds. I don't do any private practice. I can say to everybody, I don't have any commercial interests. I don't have any patents. I don't work with any company. I never receive any funding for going into any meetings, for any meals, for nothing. I am completely and utterly independent. And I'm glad to say that. I have no consultancies with any company, with nobody. But, you know, if these guidelines don't say clearly that this should be the preferred option, and again, everyone will be able to, when they go to consultation, maybe put a word to it, then it would be easy for the clinicians to go to their managers and say, this is what NICE says, we should put it into place. Because then HR doesn't do this, to my surprise, to be honest with you, because I thought that they would then make sure that this is going to be implemented, because otherwise, what's the point of doing research if then the evidence is not implemented?
Naomi, is the aim also to try and be able to spot patients early enough so they wouldn't ever need anti-VEGF? You know, you've proven, haven't you, that this is a relatively cost-effective treatment compared to injections. And we know from talking to patients that a lot of patients hate the idea of having an injection. And whilst, you know, they go and they put up with it, presumably the aim is to be able to spot all of these DMO patients early so as they would never need anti-VEGF?
Correct. And we have, in the UK, we feel very proud, very, very proud of our screening program for diabetes. We have a fantastic program. And, you know, before, even I heard that in some, and again, my screening program in Northern Ireland is different than in England, than in Scotland. Wales is a little bit more like in England. But sometimes patients are not even referred until central retinal thickness is 400 microns. So then you lost the chance to do laser. To me, that's not good, because again, you know, if the laser, of course, if your sight is down, the laser usually doesn't bring the sight up. But if your sight is still good, the laser keeps your good sight. So, you know, I think that is all now about disseminating, about people understanding. It's very important that patients know. I explain things. I try to explain it to all the patients that I see, all my patients. I explain well what are the options so that we can choose. And I always say, well, we can start with the laser. If you don't respond to the laser, I see you regularly. If I catch you because your sight gets worse, okay, I can always give you the injection. And macular edema, diabetic macular edema, doesn't cause sight loss rapidly. So there's time to play. To me, is something that we all have to do now. I'm trying to do it. You are helping me to do it because we are informing people about it. And again, you know, my hope is that, you know, in the guidance, we'll say this, and then people will know. People can go to their service managers and say, and did what I did, get the laser, hopefully catch people early, hopefully treat early. Hopefully, you know, again, you know, everyone will learn about it and will improve the care, which is what we all want.
And I was fascinated by your patient who actually required an appointment with his GP rather than with you, where, you know, is there more that whole kind of holistic view of care we should be doing in order to make sure that our patients with diabetes aren't then getting these terrible side effects? You know, what is the role of statins and all this other, and should patients be automatically being given them? Because, you know, you've shown, haven't you, with that scan, that it can make a huge difference to what's going on in the eye.
So I, again, absolutely, you know, the ideal thing would be that we have diabetes centers.
Oh,
and in the diabetes centers, we have, well, you know, we can dream big. I like to dream big. And I think that we need to pursue the best. If we pursue the best, at one point we'll get it. But I think that if we were all in the single center, and, you know, we could say, well, you know, we have the diabetologist there. I try to talk to the diabetologist and to the GPs as much as I can. So I certainly, when I see eyes that have quite a lot of lipid here in the UK, that is not that usual. I was actually visiting China at one point because we were doing a trial there, and people there have much more lipid in the retina. So if I see lipid in the retina here, certainly my brain goes into thinking, how is the cholesterol, how is the triglycerides? And I would always talk to the GP, because I would always, if they are high, I always want to drop them first, because then, as I showed you, even that plaque, that, if you see that, the next thing is, wow, the sight is going to go down with this plaque of lipid, and it clear fully. So it's quite amazing, but, you need, it's just us, and patients knowing about it. Again, I think that when you know about it, you can get engaged. And I think that, yes, totally is holistic approach, and I think we work in a team. You know your diabetes better than I do your diabetes, right? I don't know about your diabetes, but I can see how your diabetes is changing your eye. So I can talk to you and I can say, well, we need to make sure your lipids are good. Do you know how your lipids are? We need to make sure that your HbA1c, your glucose is good. That will help the eye. All these things are helpful. And I know, that it's not easy to control these things. And we were chatting before we started, saying about the food that we eat. It's much harder now to get healthy food than it used to be before. We have some choices that are not the best and are around us, and they are delicious, unfortunately, and we might not choose the right thing. But we need to know, if you don't know that your lipids are high, you don't know, you can do nothing about it. So I think that is, people knowing and doctors talking to each other. And I try to do that. And I think that this is what we need to promote. More conversations, ophthalmologists, kidney doctors, nephrologists, doctors of the heart, cardiologists, diabetologists, doctors of the diabetes. We all need to be well in touch with each other.
Integrated care.
Correct.
Questions for Noemi? Well, if not, Noemi, thank you so much. It's so wonderful, to be with a researcher who we initially funded, which is very cool, but also to see just what a difference this could potentially make for all patients with DMO. So, less invasive, less cost. It strikes me as a bit of a win. And I think there's probably something that we can do as the Macular Society, to find out where all the centres are that have these lasers, and also those that haven't, to push them to get the updated laser. So let me get Bernie.
Sorry, before we finish, I'd just like to say thank you, Noemi, so much for the work that you do in your research for people with diabetic eye disease, because I'm sure the patients and the PIF carers here, would really just like to express that thanks, because without you, we wouldn't be able to move things forward. And people like you are so important, and we do recognise that you work really hard to support us. So I just wanted to say thank you so much for that.
Well, it's like why I say to you, Bernie, because you're doing a lot of work too yourself, and you're helping us and everyone here. And I think that, we all can now, work together, and that's the great thing. And as I say to you, I would go nowhere if I didn't have the patients and the public helping in the research we do. So, this is a fantastic relationship. This is fantastic too, by the way, because other countries don't have this. They have not even thought about it. So when I was presenting diamonds in the United States, in fact, it was a United States meeting, but it's worldwide, it's attended worldwide. And they were amazed to see that people living with diabetes were part of the research that we were doing and part of the design. And they were like, and I thought, well, great, we are doing really good, because without you, we wouldn't be able to tell what is important. So I'm so grateful to everyone that takes part on research and that advises us on how to do it. So thank you.
It's so important, isn't it, that actually we make sure that patients are at the heart of all of this, because as you say, Noemi, they are the experts, and actually we shouldn't be presuming that we know what's best for them. They know what's best for them, and we need to make sure that we keep them at the heart of it. So I mean, Bernie, you're doing amazing stuff for us. We think you're the most incredible advocate, and so keep doing what you're doing, and we'll support you as much as we can. So thank you, and thank you all for joining us. We're back. Colin will be back, a familiar face, on the 29th of June at 6:30. And the speaker for that session is Dr. Gavin Arno from the Department of Genetics at Moorfield Eye Hospital. He's going to be talking about the latest advances in genomics for inherited retinal disease. So yeah, if that's of interest, join us again next month. And in the meantime, thank you all for joining. Naomi, thank you once again.
Thank you. Thanks for the invitation.
Yeah, no, thank you for giving us the time, and you can go outside and enjoy a bit of sunshine now, as can everyone else.
Take care.
Take care,
Bye-bye.
everybody. Bye.
Bye.
Bye.